Well, welcome everyone. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. Really appreciate you taking the time today to join our Innovation Beyond the Edge program. I'd like to share my screen here very briefly, talk a little bit about the season that we've had thus far. We've had a phenomenal group of presenters. Most of them are Chime members, CIOs, CMIOs, digital officers, and also not just from the US, but international, including the Chief Innovation Officer and Chief Medical Officer at Sheba Medical Center in Tel Aviv, Israel. It's really been a phenomenal program that we actually put together in the days following the cancellation of our spring forum in the beginning of March. And from that came 14 sessions. And this is our last session for season one. All of these programs can be viewed on demand. So if you're actually viewing this one on demand, welcome. But please take the time to check out these other programs that we've put together. There's a lot of very interesting innovation stories that our members have shared, and tremendous information that you can glean from them. So I'd like to say that, over the last several months that we've had this program, obviously we found ourselves as a society in some very difficult and challenging times. But with that challenge presents opportunity. And that's also the opportunity to solve problems. And quite frankly, that's really why we are here today, for creative problem solving and to highlight those that are performing that. Today, we're going to hear from Dr. Brian Herrick, the CIO at Cambridge Health Alliance, about the mission of telehealth and reaching communities. For Brian's benefit, I've got a picture of the Charles River behind me, looking at Cambridge from Boston. So I thought that would be appropriate for today. I've really been looking forward to this presentation and very much appreciate Google Cloud's support for this today. They've been great friends of Chime. Before we get going, a little bit of kind of housekeeping items, if you will. There's three main parts to this presentation. One, we're going to hear from Brian about 20 minutes. He's going to talk about telehealth, and then we're going to have a breakout session, and that's going to be through the Zoom breakout room function. We're going to have virtual roundtable discussions, and those will be about 15-20 minutes, enabling Chime members to be able to have intimate conversations about this topic and to really to interact with each other on that. And then the third part is a Q&A session. So we'll come back from those breakout rooms and have that Q&A session. So throughout Brian's presentation, feel free to ask questions in the chat window. You'll see that at the bottom of your screen. And when we come back for that Q&A, I'll go through the questions, and we'll have a nice conversation with Brian on the topic. A little bit more boilerplate that I've got to actually read, so forgive me on that. We'll have everyone muted during the session. If you'd like to ask a question, please use the chat function to alert the team. Chat window will appear on your right side panel. To ask the question, type your message inside the panel and press the send key. Questions for Brian can be posed there, like I mentioned before, and I'll ask those at the end. Also, we're recording this presentation. This will be saved and stored on the Chime site. We will not be recording the breakout room conversations. Those are designed to be more intimate conversations amongst Chime members. If you have difficulty listening to the live audio stream, you can certainly call in as well. If you have called in and you're joining us on your computer, please let our host know, and Ashley will join those. If you don't do that, your phone connection may go into a different breakout room than your computer. So we don't want that to happen. We learned that from the first session. So, iterating and learning as we go. Lastly, by attending this session, the full session, including the presentation and virtual roundtable discussion, you will earn 1 continuing education unit for CHCIO, CFCHE, and CHISL certifications. We'll review the attendee list following this and distribute the CEUs accordingly. So with that being said, it's my pleasure to introduce Chris Sakalowski, the Managing Director of Healthcare and Life Sciences at Google Cloud, to introduce our speaker for today. I really appreciate both Chris and Google for being just tremendous friends of Chime. We appreciate the support of Innovation Beyond the Edge. So Chris, if you could take it away, please.
You bet. Thanks, Jonathan. Very much appreciate it. It's a pleasure to be here with you and the rest of the groups listening in today. As you mentioned, my name is Chris Sakalowski. I'm the Managing Director for Google's Healthcare and Life Sciences division here. So first of all, before we get started, I'd like to double down, Jonathan, on something you said. And I'd like to acknowledge the gravity of what we're all collectively experiencing. The path to recovery from a pandemic, as well as the social justices that we are seeing sweeping our nation, the path is very, very thorny. It's arduous and convoluted at best. And as a society, we must bravely take small steps towards the bright future. In our domain, I am seeing those small steps happening of healthcare providers partnering together and leveraging data to better understand how COVID-19 is affecting our communities, of providers and their organizations, gathering the visibility into how they can better serve the most vulnerable communities and those who just don't have access to quality, affordable care today. We've seen first responders and healthcare organizations that have quickly pivoted, quite frankly, to take care of their patients in a new normal with new formats, omni-channel, if you will. And it's something that we've been quite humbled by to observe and be a part of each and every day. You know, one organization I've had the pleasure to work with in these coming weeks that I think has done a phenomenal job in this particular forum and is in telehealth, and that is with our partners at Cambridge Health Alliance. I'm happy to introduce today's speaker, Dr. Brian Herrick, their Chief Information Officer and a good advocate of ours here at Google from Cambridge Health Alliance, and is also a great member and friend of the Chime organization. Before I introduce Brian, I just want to give just some brief background. Dr. Herrick he joined CHA in 2010 and was named Chief Information Officer in 2019. He's jumped right in from an innovation perspective and from a transformation perspective, looking at what was coming through his front windshield, also a strong understanding of the past and what he could really do to drive up patient quality and the provider satisfaction, which is no easy juggling task in of itself. Quickly took a look at what they were doing from an EHR perspective, looked at the MyChart patient portal and guided CHA through many stages of meaningful use, including ensuring that the organization had a chance to achieve their highest payment from those incentive programs. He's worked with regional healthcare leaders to create a standard in the EPIC function, care everywhere, to promote their interorganizational information exchange and to the benefit of patient care. And he's recently helped CHA to spin up quickly their telehealth initiative, which we'll be talking about quite a bit today. I look forward to what he has to share, both the goods and the bad, the uglies, and what he's learned and what he can share with each of you, and I'm sure you are as well. So I'm very, very fortunate to have had a chance to work with Brian over the past few weeks. And without further ado, I'd like to turn the floor over to him. Brian, please take it away.
Thank you very much, Chris. That was quite an introduction. All right. So I wanted to start off with a little bit of background about Cambridge Health Alliance. So we're a safety net public health system north of Boston. We have academic affiliations with Tufts and Harvard. We have about 125,000 primary care patients, 2 hospitals, 15 specialty and primary care clinics. 75% of our patients are public payers. 50% of them speak a different language. And 50% of our patients are in some sort of ACO contract. So population health and public health is really where we focus. We're known for our primary care innovation, our behavioral health integration, and our strong mental health services. I'm sure that you've all had quite dramatic changes in your organizations. And it seems everybody's experience is either very different in certain ways or very similar in different ways. So what I wanted to talk about is a little bit of our experience of COVID and what we went through during the surge. Our surge, as you can see here, started in mid-March. And we were soon over 200% of our maximum capacity for our critical care units, which we sustained for over a month. And currently we continue to be over our normal maximum capacity for our critical care patients. We've really come to define a new normal for our critical care services, and that's where we are right now. And as you can see in these graphs, where the blue is the COVID cases and the red is the non-COVID case, red is the total. So our critical care capacity was significantly, the majority was COVID cases. And on the right here, you can see our capacity. Remember, we're a community health organization, so critical care was not difficult for us, but we were able to respond by opening 2 accessory ICUs in the PACUs and peri-op areas. We created an alternative care site at Tufts University dorms to manage post-COVID patients, post-discharge COVID patients. We also had community management programs and 2 comfort centers, comfort care centers that we created. So in this slide, you can see what the surge looked like from the ambulatory encounters in our community management program. This was an innovative program that managed COVID patients, positive patients, and patients with respiratory illness at home. We also were able to quickly get 3 drive-through testing tents for COVID for our patients, our employees, 3 first responders, and eventually, as we got more supplies, we were able to do it for our entire communities as a public health measure, even non-patients of CHA. We continue to track our community rates of COVID. Of note, even though our total testing has decreased over time, we still have very high rates of positive tests in some of the communities with the lowest socioeconomic status, as you can see in these the green and orange lines of the different communities. So, what were the challenges to managing our population during this time? As I'm sure you all know, you had your own challenges. Well, let's think about it from the patient perspective. Think of the person with uncontrolled diabetes needing active management of their foot ulcer to prevent amputation, and who's hesitant to get care because they don't want to contract COVID. Think of the person who is feeling short of breath and has chronic lung disease, being fearful if they leave the house to get care, they'll contract COVID and die. There was and still is a lot of uncertainty, feelings of helplessness and fear out there. Now think of those same people and add on that they just lost their job or that they can't go out and get food. Childcare has been eliminated. They live in a multi-generational apartment with very little ability to quarantine or physically distance, relying on public transportation to get to all their appointments, unable to stockpile toilet paper because they have no room. Oh yeah, and they don't speak or understand English. This is not an uncommon scenario for our patients and dramatically impacted them more so than other populations. From our caregiver perspective, we had to continue to manage a vulnerable population that was surging early and quickly. We had to completely uproot our model of care, as you all did, in a week's time. We not only needed a mechanism of communicating with our patients, our communities, and monitor them over time, but also we needed a way to connect with them in a culturally congruent way and provide resources to help them to know how to stay safe, how to access the resources that are out there, and when and how to access care if they needed to. During this time of crisis, we worked closely with our partners, joined together to solve these problems and move forward. In this moment, we really relied on our partner Google to help us rapidly deploy telehealth solutions for the entire organization. 2 weeks ago, we also implemented the first instance of Google Meet's integration into Epic, which is really quite an exciting milestone. We decided to work with Google for our telehealth services for multiple reasons. Google provided a platform that was secure. And at that time, there were lots of questions out there about what did security mean. It was something that our providers and staff were already familiar with. And since we had been a G Suite customer for 5 years, and we wanted a single telehealth solution, which would help streamline our implementation, our training, our support of staff and patients, because everybody needs to be a part of this. And we hope in the not so long future, Chrissy, this is for you, Google and Epic will agree on terms to provide deeper integration into clinical workflows. We partner with Google because I really feel like it's the long-term solution. It's the way to go. So there are many benefits to the telehealth for patients. There's convenience, reduced cost of travel, less time out of work, reduced risk of COVID exposure, providing an easy way to hand off patients to specialists and other providers, easier to conference in advocates and interpreters, which is a real important need of ours, and really potentially decrease no-show rates. It also provides a different perspective from the patient side. It allows us, if they're willing, to go into their homes and see what their lives are really like, which is just a deeper connection to who they are. So it's great, right? Well, remember those patients I talked about earlier? Let's add on that they don't have high-speed internet, that they don't have unlimited data on their flip phones, that they don't have camera to connect to for video. Understanding that technologies can be a good solution for many of our issues, but we need to be conscious of the disparity and the potential inequity it creates when not everyone has access to the same solution. Many of these barriers are real and are things we cannot overlook. That's why we need to continue to advocate for payment for audio-only televisits so that we can continue to serve those disadvantaged populations in the patient-centered way that meets their needs. In our population, we did a survey of patients via email, which I understand creates some selection bias, but provided some insight into from their responses. Even of the population who had emails and responded to the surveys, more than 50% of them did not want to use video due to internet connection, privacy concerns, gaps in technical knowledge, or just their general comfort with inviting a provider or healthcare provider into their house by having their cameras on. In our efforts to better understand this, we're working on ways to further understand digital divide as a social determinant of health. I would encourage every one of us to continue to think about how we can. As I mentioned before, we were able to connect caregivers with patients over Google Meet for telehealth. Our community management program took patients with respiratory symptoms and managed a significant number of outpatients using telehealth services, providing O2 sat monitors for patients with hypoxia for home monitoring, and using telehealth visits to check on them frequently. This prevented ED visits and really was a positive service for our patients. In all of our ambulatory services converted to televisits and ramped up close to our baseline. About 10% of our televisits overall were video visits. But you can see here that our baseline, when we converted over March 15th to televisits, we were quickly able to recover and reconnect with those patients that we need to. Even our orthopedic department got up to about 25% of their normal volume using televisits, which is usually a very resistant group and very hands-on. So really impressive. But our star performers were the psychiatry department, doing group televisits for mindfulness and substance use disorders, televisits for mental health counseling, screening remotely for worsening or new mental health disorders, and teleconsults for inpatients and the EDs. They basically converted all of their outpatient visits to televisits in a week. Pretty impressive, really remarkable. So let's talk about a few other use cases. We started doing telehealth consults in inpatient, so to help cover the increased demand, decrease the exposure of our consultants, conserve PPE, and cover multiple campus locations. The consultants would collaborate with primary teams, and could do either telephonic consults with calling the patients directly into the rooms, or they could do video consults. To facilitate this, we created a new position for redeployed personnel. Because we closed all of our outpatient clinics, we redeployed all of them to be telehealth teleconsult liaisons. We didn't deploy them all to be telehealth liaisons, but some of them. The consultants would contact the liaisons. The liaisons would go up to the patient's room and perform video consults via Google Meets. These services were used in multiple different specialties across the organization. Although after rolling this out in the first few weeks of the surge, it became apparent that the liaison's time was better served doing something else. As no visitors were allowed, the patient's only human contact was a member of the team, inpatient team, who would come in dressed in Tyvek suits head to toe. They would have masks on, gloves on, booties on, head covers on, face shields on, and they tried to keep their distance from the patients whenever possible. Limiting patient contact was important, but for the patients, they were isolated and scared, some without the ability to connect to their loved ones. The liaison role evolved organically, and we found they were best used to connect patients with their family members or to facilitate family meetings with the care team virtually. We had created 2 comfort care centers to help support our patients in their last hours. The stories from these redeployed staff to comfort care centers were just truly inspirational. Members of our comfort care centers spent countless hours connecting with family members who were unable to visit with their loved ones. You can just imagine the pain of not being able to visit your family member as they are dying in the hospital. A nurse who spent hours over television over televideo with a patient she knew did not have a family to comfort her and help her die peacefully. Multiple examples of compassionate inclusion of families and connecting with patients in the last moments of their lives. They caringly created space for tender goodbyes, which would not have been possible without these technologies. These technologies also gave patients hope and strength to improve. A patient that was not responsive to a medical team, and when the medical team was able to connect the patient with an interpreter that they actually were familiar with, she woke up and responded and brightened up. Just a testament to the importance of this cultural, competent care and allowing that connection to happen. A medical assistant connecting family members to a failing patient on the medical units, providing him with encouragement to eat, get stronger, and ultimately get discharged. These are the successes that the telemedicine work has really provided. There are countless stories of how these technologies in compassionate hands can connect people who are disconnected and help change the care we provide for the better. So, in closing, telehealth is here to stay. To get through the crisis, we have leveraged multiple different technologies. Telehealth will continue to be an extremely powerful way to create connections where it otherwise would not be possible. For some, it will also be more convenient, more accessible, more cost-effective, and ultimately more efficient for the system. For CHA, Google has played a large part in our ability to quickly meet this condition. Even though one surge is improving, there is likely another crisis on the near horizon. I'm not talking about the critical care beds or the ventilators or even the PPE, which will continue as being crises. I'm talking about the mental health crisis that is coming, as we all have gone through significant trauma. The recovery will be significant. We need to focus on these populations that are isolated, fearful, and dealing with mental illness. Over the last few days, CHA has seen significant increase in the acuity of our psychiatric units and very high numbers of those needing patient safety watchings and one-on-one sitters because of risk of harming themselves. Creating programs to reach out and monitor these patients will be critical, and technology will have to play a large role in this. If we can take anything positive from this pandemic, it's been that our community's ability to adapt to using these technologies. Let's leverage that as much as possible so that we can focus more resources on the populations who require high touch and more support to improve their health. Inequity and disparity is real, so let's prepare for it. Thanks. Thank you.
Brian, thank you very much. Very much appreciate your presentation, as well as what you're doing to serve these populations and connect through telehealth. It's truly making a difference. We very much appreciate you spending the time walking through that and the work that you're doing. So thank you. Brian, I've got a first question for you while we're waiting for some questions to come in. You know, a couple of years ago, I had an opportunity to learn from Dr. Abraham Verghese at Stanford, big advocate of the healing touch that physicians provide. And, you know, I'm just wondering, as a physician yourself, can you talk a little bit about some of the specific, you know, telehealth elements or aspects that you've seen either replicated or replace some of the in-person, you know, visits with patients, and certainly also if you can address, you know, for those patients that may not have, you know, a nice computer or may not have a nice smartphone to engage with. If you can address that, I would love to hear it.
Yeah, well, I don't think that there's going to be a one size fits all. I do think that we will need to focus more around the chronic disease management in areas where there's already an established relationship, that there's an understanding of who the person is and understanding of what that relationship is and focus on that for the telehealth visits. The urgent care, the areas where people are having acute illnesses, I think are more going to continue to be in person for for the foreseeable future. But I think that the chronic disease management is really where we need to focus for televisits. For the patients that really don't have the availability, we are going to have to meet them where they are. Even for phone visits, there's lots of patients who do not want to have a phone call because they don't have a private place in their house to have a conversation that they want to share with their entire multi-generational family. And so we are going to have these systems that support those connections and provide the care that we need to for the most vulnerable patients. You know, you think about domestic violence and things like that. It's really critical that people are coming in to for in-person visits for many of these screening and conversations.
Excellent, thank you. You know, as you're talking about some of the steps that you've been taking, obviously implementing new technologies, solving problems, you know, and just overall steps that you've taken for your organization to be more innovative, especially during these times. How do you foresee sustaining that innovation? How do you foresee being able to continue that? And are there internal partners or internal allies that you've worked with to help carry that message? Would love to hear your thoughts on that.
Oh, that is great. I just love that question because we have learned so much from this crisis. We have learned that we can, you know, change on a dime and completely change the care that we deliver. We can be agile and work together with one goal in mind, one purpose, small change, proof of concept, and iterate that over time. That's what at least our organization has really learned that and felt that, and felt the alignment of all of the departments going in the same direction. You know, a common enemy, it just aligns everyone in the same direction. And thinking about how do we recreate that in other situations for us to be aligned, be focused, be clear on the single outcome that we want to create, is going to be the challenge to continue this iteration. And it really all comes down to value. What will bring value to our patients, to our communities, to our providers, and our healthcare system is really what it comes down to.
So you made a good point there, is that, you know, prior to this, you know, there may have been we can't get it done in this time frame, or we don't have the resources to get it done. And there have been some just tremendous monumental, you know, problems solved. And where there were perceived roadblocks, they really weren't there, or people banded together to really overcome those. Are there, you know, in the last you know, few minutes that we've got, are there other friction points and kind of creative problem solving that you and your team have engaged in that you'd like to highlight? You know, any kind of proud moments of your teams, or any just, you know, it could be even just the smallest friction point and the smallest thing that might seem insignificant, but, you know, could be helpful to your peers, and recognizing that these sort of problems can be overcome through, you know, creative means. And, you know, I'm a huge proponent of, you know, it doesn't have to be a bright, shiny object. So would love to hear any examples you'd like to highlight in the last few minutes we've got.
Yeah, I mean, the example that comes to my mind is that being flexible and being willing to change based on what the issues are that are being presented. So we had the plan of doing these e-consults or teleconsults for the inpatients. And we needed to listen to the people that were out there. It was not a big change, but we had not thought that patient to family and family meetings was going to be the critical piece to provide this extraordinary care that people were missing, this piece of the puzzle that was missing from their care. We hadn't anticipated that. And so for us, it was really listening to what do they need? What are our patients saying? Where are the gaps? And so it wasn't like an aha moment. It just kind of morphed. and people used, had used their initiative and just dove in where they were needed. And so I think that was a big piece for us.
Excellent. Well, Brian, we really appreciate your time today. Appreciate you presenting on this important topic, as well as being able to share your insights and successes with your peers. We're going to be sending out an email to all the attendees that includes a survey, and we'd love to have your feedback. This was our 14th session for our Innovation Beyond the Edge. We plan on doing a second season kicking off in late July or early August. So any of the folks that are on here that love to present and talk about the creative problem solving that they've engaged in, please reach out to me or to any of the Chime team members. Thank you again to Google and to Chris. We really appreciate your support for this program. Without partners like you, this simply would not be something that we could do. So a couple of upcoming events that we've got. June 24th is a new program called InnoCast, and that's designed to be really highlighting a partnership between a health system, CIO, as well as a startup company that really helped that CIO solve a real problem that they faced through innovation and through partnerships. And like I mentioned, we've got the second season of Innovation Beyond the Edge that will be later this summer. So last but not least, I just wanted to thank you for your time and your attention. We really appreciate it, and have a wonderful day and be well.